All right. Okay. I apologize in advance for the poor quality of this video. This case is from 2020, uh, and not all my ORs are equipped with the best cameras at that point in time. But nonetheless, I thought there was some teaching value and some learning value from this case. Hi, Mohammed Al-Mala here. We are doing a case series on small pupil cataract surgery. This is case number 5 of the series. Make sure you check out the whole series in the playlist, which I'll link to in this video. This patient obviously has pseudoexfoliation. How do we know that? Well, you see the material in the anterior lens capsule. You see 2 rings there. You see 1 ring close to the iris margin, and you see an inner ring of pseudoexfoliation material. The material is deposited on the anterior lens capsule, and you can see an area where there is no lens material deposited. There is no pseudoexfoliation material deposited because that is where the iris moves back and forth. So, what do we need to look out for when we're doing cataract surgery in a patient with pseudoexfoliation? Number 1, pseudoexfoliation patients may not dilate well, as we can see here. Number 2, the pseudoexfoliation material can make the zonules lax, and that can make cataract surgery more difficult for multiple reasons. It can make it more difficult to do the capsulorhexis. It can make the posterior capsule more floppy and make it more likely that you capture the posterior capsule in your phaco probe and get a posterior capsular rent. And number 3, because of that zonular laxity, it can make the IOL outcome or the final IOL position or the effective lens position less predictable. So these patients can have a higher risk of a refractive surprise. So you can see here, this pupil is probably about 4 millimeters. We're able to complete the capsulorhexis. We're going to go in here and do hydrodissection. We've got to be careful here that we don't get iris prolapse. So we tent up on the anterior capsule, but there it is. We get some iris prolapse. As soon as it starts prolapsing, we stop injecting. We push on that posterior lip of the wound. We decompress the anterior chamber, and that allows the iris to fall back in. Do not push the iris back in without decompressing the anterior chamber first. The iris is a very soft tissue. It's going to follow whatever pressure gradient you give it. So if you increase the pressure inside the anterior chamber and it's more than the pressure outside the anterior chamber, the iris will prolapse. And if you try to push it back in, it will not work. You have to decompress the anterior chamber first. So we are doing a horizontal chop technique here. This is with the Bausch & Lomb Stellaris machine, a Venturi system. We have chopped and isolated one quadrant, and we've been able to remove that quadrant. We got a good rotation here. And if you're doing a small pupil case like this and really don't have much visualization, it's important. 2 things are very important. Number 1, that you get a good crack. Number 2, that you have good rotation. If you don't have either of those, this case can be significantly more difficult to do, and at which point in time you can go ahead and put in iris hooks or do whatever you need to do to get better visualization of this lens. So far, we've got 2 good things here. We've got a good crack, and we have good rotation, so we're able to break up this nucleus into smaller pieces and pull those out with our very efficient Venturi system here. So as you can see, we're working within that small pupil. I already have my second instrument behind the nuclear material. We want to keep that posterior capsule back, especially in this patient who has pseudoexfoliation. So we're making good progress here. And I think that's all the nucleus there. And so we just have a little bit of cortical material remaining, and we're going to go in with the IA probe and remove that cortical material. So while I'm waiting for my tech here, I'll go ahead and put some BSS through the paracentesis. That helps me maintain the anterior chamber, number 1. Number 2, it also helps to remove any kind of lens material that may be hanging out in that paracentesis, so we can remove it as we do IA here. Irrigation aspiration, we'll go in and we'll aspirate out that remaining cortical material. In a patient with a small pupil, it's easy to grab the iris when you're doing this. And so we want to be careful not to grab iris as we remove this cortical material. So check out the playlist for all these small pupil cases. I'd love to see how you do your small pupil cases. This is a Charvel, an instrument to retract the iris. I'm looking for any remaining cortical material. I now do this part usually after I've already put the IOL in. I like to have the IOL in and have that scaffold in place to protect the posterior capsule from my IA probe. Looks like I'm doing some capsule polish here with the back of this IA handpiece. I also sometimes use the Terry squeegee to do capsule polishing. But we're making good progress here. So I'm probably going to inject Provisc now, cohesive viscoelastic. Oh no, we're going to do Terry squeegee. We're going to polish that posterior capsule some more. And this is just a cannula with a silicone sleeve that you can use to irrigate as well as polish the posterior capsule. You can mechanically polish with the tip of the silicone probe. You can also polish with by irrigating. So two mechanisms by which that Terry squeegee can polish the posterior capsule. Injecting Provisc here to fill the capsular bag in the anterior chamber. Watch out for iris prolapse here as well. We're going to inject our IOL, probably a single piece hydrophobic acrylic IOL here. Let's see. Yes, that looks like a Technis IOL. And here I am using a Lester to make sure that the IOL is inside the capsular bag. We want to make sure that those haptics are starting to unfold. And then we'll go in with IA and remove that viscoelastic from the anterior chamber. I like to go behind the IOL, not to leave any pockets of viscoelastic present. And that's really about it for this small pupil case. That case went really well. Remember, for these small pupil cases, especially in patients with pseudoexfoliation, you got to be able to get a good crack, number one, and you got to have good rotation. That makes all the difference in being able to do these cases without having to use a pupillary expansion device. Also, the phaco chop or horizontal chop makes it easier to do, makes small pupil cases easier to do because you don't need to require visualization of the periphery like you do when you're making a groove for divide and conquer. This is the corner one, which I'm also using to do the same thing, retract the iris, looking for any remaining cortex that may be there. So now we'll hydrate the wounds. We'll hydrate the main wound first. It looks like we're still looking for some more cortical material there. There must be something there that I saw that I'm looking for. So let's see here. Nothing really too much on this video. Sometimes, obviously, with this, especially with this video, we're not seeing all the details that I can see intraoperatively. Oh, there we caught up some iris there with our IA probe. Not a big deal. We let go immediately. Don't keep pulling on the iris, and it does make the pupil come down further when you do that. So looks like we are done. We're going to hydrate the wound. We're going to irrigate the anterior lip of that main wound first, and then we're going to fill the anterior chamber through the paracentesis. And we'll check the pressure here with the 30 gauge cannula, Balot on the cornea. Make sure we're happy with the pressure. And then we'll check the wounds with wet cell sponges. I always check the wounds with wet cell sponges. I always want to make sure that it's nice and watertight. Don't want to have to be guessing whether it's watertight or not. And that's it for the case. Thank you for checking it out. I hope you learned something from this. Leave any questions or comments in the comment section below. Thank you very much for your attention.